Hello and welcome everyone to NDARC's weekly webinar. My name is Tom Santo Jr. and I'm a postdoc research fellow at NDARC. I'm thrilled to be hosting today's session where we'll explore the influence of retention in opioid agonist treatment on substance use, health, and service utilization among men recently released from prison. Before we begin, I would like to acknowledge the Bedegal people who are the traditional custodians and owners of this land, which I'm presenting on today. I would also like to pay my respects to elders past and present and extend that respect to any Aboriginal and Torres Strait Islanders people who are present today. Now it's my great pleasure to introduce today's presenter, Dr. Michael Curtis. Dr. Curtis is a postdoc with the Disease Elimination program at the Burnet Institute and a research associate at the National Drug and Research Institute at Curtin University. His work is focused on the health and well-being of marginalized groups, particularly those in prison and people who inject drugs. He has a significant experience in both prospective surveys and in linked administrative data, and which makes him very welcome to present on today's topic and a great interest of mine. And so I'm also pleased to introduce Professor Mark Stoové as a panelist for today's Q&A session, which we'll have at the end. So Professor Stoové is a head of public health at the Burnet Institute and has led groundbreaking work on the epidemiology and prevention of bloodborne viruses and sexually transmitted infections, particularly among marginalized groups. His work has had a profound impact in Australia and internationally, particularly in the justice health space, with over 200 peer-reviewed publications on these topics. So today, Dr. Curtis will be presenting on the impact of retention of OAT on substance use, health, and service utilization. So, Michael, the floor is now yours, and please turn on your mic and camera when you're ready.
Great. Thanks very much, Tom. Just bear with me while I get set. So I would also like to start by acknowledging that I'm on unceded Aboriginal land. I live and work on the land of that's been cared for by the Boon Wurrung people of the Kulin Nation for millennia. I wish to pay my respect to their elders past and present and extend that respect to all First Nations people in the audience today. I'd also like to acknowledge any people with lived experience of incarceration, opioid dependence, or use of opioid agonist treatment that may have joined today as well. So opioid agonist treatment, or OAT from here on, is the primary treatment option for people experiencing opioid dependence here in Australia and many other countries around the world. It involves the prescription of a pharmaceutical opioid, which here in Australia will either be methadone or buprenorphine, including a few different formulations of buprenorphine, to treat the symptoms of opioid withdrawal and manage opioid cravings. According to the most recent NOPSAD data, which is an annual census or sort of cross-sectional survey of the number of people receiving opioid agonist treatment around the country, there were just over 50,000 people receiving OAT, and almost 6,000 of these were in prison. So why might OAT be important for people involved with the prison system? In Australia, as many other countries around the world, people who inject drugs are disproportionately imprisoned compared to the general population. While only 1.5% of the population report lifetime injecting drug use and 0.2% report injecting drug use in the last month, almost 1 in 3 people entering an Australian prison report injecting a drug in the last month. And looking specifically at opioids, a New South Wales retrospective data linkage study found that almost 40% of people who experienced opioid dependence were imprisoned at least once in their lifetime. And while periods of imprisonment are often accompanied by reductions in drug use or even periods of cessation, the resumption of drug use after release from prison is associated with a range of adverse post-release outcomes. These include an increased risk of recidivism and reincarceration, homelessness, psychiatric distress, and most concerningly, a substantial increase in the risk of death. Many of these adverse outcomes are particularly elevated amongst people who use opioids after release from prison. Accordingly, there's a clear need for evidence-based interventions to reduce post-release opioid-related harm. And previous Australian research led by NDARC has found that retention in OAT during transition from prison to community supports improved outcomes in some of these domains, including large reductions in the risk of opioid-related mortality and modest reductions in the risk of re-imprisonment. However, prior to the work that I'll present today, there were some things that we didn't know about the impact of OAT in that post-release period here in Australia. For instance, we lacked Australian research regarding the impact of OAT on the frequency of post-release injecting drug use, or how access to OAT influenced patterns of post-service health service access, whether it supported improved health outcomes. And additionally, our most recent data describing treatment retention during the transition from prison back into the community were more than 10 years old, and all were derived from New South Wales. So the work that I'm going to quickly present today came from my PhD, and it explored or examined some of these gaps through a series of 5 studies. The data underpinning these studies all came from a study, the Prison and Transition Health Cohort Study, which was led by Professor Mark Stoové, who, as Tom said, is joining us on the panel today. Briefly, PATH was a prospective study of 400 men who we recruited in prison and interviewed shortly before their release from prison, and then completed a series of 3 follow-up interviews over the following 24 months. We recruited the participants between September 2014 and May 2016. Participants participated in an interview which included questions about a range of different substance use, health, and mental health and physical health conditions, pre-release planning, and of a range of socio and demographics. Participants also consented to researchers accessing linked administrative data from different health, social service, and justice-related data sources for 2, 5, and 10 years after release from prison. And if you're interested in more details about the PATH study itself, the study 12 in my references at the end is a link to the baseline paper for that study. So the first study that I'll present today examined the resumption of injecting drug use in the first 3 months after release from prison. So while 2 previous Australian studies had examined resumption of injecting drug use after release from prison, both were conducted in Queensland, which until recently had lacked a prison-based OAT program. So as such, neither of those studies had examined the impact of retention in post-release OAT on post-release injecting drug use activities. Additionally, these studies also included people who may not have been injected prior to imprisonment. So for this analysis, one of the 2 primary outcomes was the post-release frequency of injecting drug use, which we measured in the 30 days preceding the 3-month follow-up interview. And we categorised this as people having either engaged in no injecting drug use in that 30-day period, infrequent or irregular injecting drug use, which corresponded to sort of less than weekly injecting drug use, and then people who are injecting regularly, which we defined as sort of weekly or more frequently. And amongst the 195 participants included in this analysis, 83% reported injecting at least once after release from prison. And at that 3-month follow-up interview, just under 1 in 3 reported no injecting drug use, 23% reported less than weekly injecting drug use, and just under half reported injecting weekly or more frequent. And in an adjusted ordinal logistic regression model, we found that retention in OAT was associated with a 50% reduction in the odds of increased injecting drug frequency. However, interrupted OAT use was not associated with reduced odds of increased injecting drug use frequency, underscoring the importance of supporting retention in OAT following release from prison. Additionally, we also identified several other factors, including unemployment, poor psychological well-being, age, pre-imprisonment injecting drug use, as being associated with increased injecting drug use frequency after release from prison. Collectively, these findings can inform efforts to reduce the harms associated with injecting drug use in the months immediately following release from prison. But the second study I'll briefly present today examined non-fatal opioid overdose after release from prison. So while there had been a couple of previous Australian studies examining fatal opioid overdose, finding high rates of overdose compared to people who had used opioids but were not in prison, and that those opioid overdoses were particularly concentrated in the immediate post-release period. Prior to this study, there'd only been one other study that had examined non-fatal overdoses in the post-release period. And this study also came from Queensland. And in that study, they found that non-fatal opioid overdoses occurred at a rate of 4.5 events per 1,000 person year. However, so this study came from the same cohort as the study previously, but it likely included people without histories of injected drug use who would then be at a lower risk of experiencing an opioid overdose. Additionally, that study happened in Queensland also may not correlate well to other states such as Victoria, where we know that there's much higher rates of heroin use amongst people who are using drugs. So it's likely that that previous study from Queensland may have underestimated the incidence of non-fatal opioid overdoses in the immediate post-release period. So for this study, we linked to data from Ambulance Victoria to calculate the incidence of non-fatal opioid overdose in the cohort. We define non-fatal opioid overdoses as any contact with ambulances, which included both naloxone administration and then a subsequent improvement in the Glasgow Coma Scale. And we observed 47 people contributing a total of 70 non-fatal opioid overdoses, with opioid overdoses occurring at a crude rate of 57 events per 1,000 person year, an overall rate almost 13-fold greater than the rate previously reported in Queensland. And when we stratified the overdose incidence by the days since release from prison, shown in the figure there on the screen, we can see that the overdose risk is highly concentrated in that immediate post-release period. This pattern's consistent with the previous Queensland study, as well as a number of local and international studies examining fatal opioid overdose. While we had some methodological constraints which precluded us examining the impact of retention in OAT on these patterns of fatal opioid overdose, given that the risk of non-fatal opioid overdose has shown to increase with increased injecting drug use frequency, the findings of the study that I just presented previously and what we know from pre-existing work around the effect of OAT on fatal opioid overdose suggests that retention in OAT is also likely to reduce the risk of non-fatal opioid overdose to release from prison. The third study that I'll present today compared rates of use of community healthcare contact according to whether people accessed opioid agonist treatment. So people who experience incarceration typically have poorer health compared to the general population and experience a rapid decline in health following release from prison. Previous Australian researchers found that contact with primary healthcare in the first month after release is associated with an increased use of a range of different health services. However, this study didn't account for the use of OAT. Given that OAT in Victoria is prescribed exclusively within primary healthcare settings, so we don't have any public clinics in Victoria, and that people seeking to remain on OAT are required to engage with a GP for that ongoing script within 7 days of release, retention in OAT during transition from prison to the community may support increased use of a range of primary healthcare services compared to people who didn't access OAT. So for this study, we linked the self-report data with Medicare claims data to examine use of standard, extended, mental health, after-hours DP services, and also looked at rates of pathology service access in the first 3 months after release from prison. We use generalised linear models with a negative binomial distribution to estimate the associations between the mean count of each of these 5 outcomes and OAT use post-release, adjusting for a range of other covariates, which are shown there at the bottom of the table. And we assigned people to either having no, partial or complete OAT coverage, so with complete being people who were continuously retained in OAT from release to prison to the day of interview. And we found that people who accessed OAT also accessed a range of primary healthcare services at an elevated rate compared to people who didn't access OAT. The increased rates of access of standard consultations were not at all unexpected, given Victoria's lack of OAT clinics and that people would be required to access those standard consultations in order to be retained in OAT. But we also observed increased use of a range of other health services, including mental health consultation and pathology services. So these findings suggest that OAT may support increased rates of primary healthcare contact in the first 3 months of release from prison, and this may play a role in either supporting or addressing other concurrent health matters, which we know are a big concern for people with opioid dependence transitioning. The fourth study that I'll briefly touch on today sought to compare rates of contact with emergency healthcare between those who did and did not access OAT after release from prison. So there's been a number of previous studies that reported high rates of contact with emergency departments and ambulances among both people who inject drugs and people who are recently released from prison. However, prior to this study, there had been no Australian study, and very few globally, that had examined the impact of retention in OAT during transition to prison to community on rates of contact with emergency healthcare. So for this study, we linked the PATH self-report data with ambulance data and with Victorian Emergency Department data, and using similar methods to those in the study previously, we found that complete OAT coverage or retention in OAT between release and the follow-up interview was associated with a 65% reduction in the rate of ambulance contact and a 56% reduction in the rate of ED contact in the first 3 months after release from prison. However, we found no association between people who reported partial OAT coverage during that post-release period and rates of emergency healthcare contact. And these results were broadly consistent with the number of international studies, as well as a number of studies among community recruited cohorts of people using OAT, which have also shown reduced ED contact amongst people retained in treatment. And while not explicitly examined in our study, given that the results from the first study examining resumption of injecting drug use indicated that retention in OAT was associated with a reduced frequency of OAT, it's likely that retention in treatment reduced the incidence of drug-related harms such as opioid overdose, injecting-related injuries and infections, and drug-related violence. However, most of the ED contacts were not actually coded as being drug-related. So while it's possible that this may relate to coding issues within particularly the ED, which we know sometimes aren't as reliable as we may hope, it's also plausible that retention in OAT may have other benefits that aren't directly related to reduced opioid consumption. And given the findings of the previous study, retention in our OAT may have also been reducing avoidable or sort of subacute or non-acute ED presentations. And we know that for some people, particularly who've recently been released from prison, that use of the ED for non-acute health matters can be a common theme. So the final study that I want to touch on today examined discontinuation of OAT amongst PATH participants released from prison. So far, our studies point towards a substantially greater occurrence of post-release drug-related harms among men with histories of injecting drug use than had previously been described in Australia, but also suggests that retention in OAT reduces the incidence of some of these harms and also may support increased rate of primary healthcare contact. However, when we specifically examined retention in OAT in the cohort, we found that half of people released from prison on treatment discontinued their treatment within approximately 2 years of observation. And this occurred at a crude rate of 46 events per 100 person years. But most concerningly, we found that 70% of people who discontinued their treatment did so between release from prison and the first follow-up interview, which coincided with that period of elevated risk for non-fatal opioid overdose that we also observed. And this finding is broadly consistent with research from New South Wales, which had reported a median post-release treatment duration of just 63 days. So this finding suggests a clear need for initiatives to support improved retention in OAT post-release. And when we used a discrete time survival model to examine factors associated with the first event, OAT discontinuation, we found that Aboriginal and Torres Strait Islander peoples and people who initiated the OAT episode in prison, so this is compared to people who were already on OAT when they entered the episode of custody that they were recruited to part from, these two groups were at a substantially elevated risk for treatment discontinuation. So through these 5 studies, we found previously estimated rates, much higher than previously estimated rates of returning to injecting drug use and incidence of non-fatal opioid overdose in a cohort of men who regularly injected drugs prior to imprisonment, highlighting the need for effective treatments such as OAT, as well as other harm reduction interventions among people leaving prisons with histories of drug use. We also found that retention in OAT reduced the frequency of post-release injecting drug use and was associated with different patterns of healthcare access, namely increased primary healthcare and reduced emergency healthcare contact. Collectively, these findings add additional evidence for the importance of supporting retention in OAT following release from prison amongst people with opioid dependence. However, our findings also showed that post-release retention in OAT is suboptimal, pointing to a need for additional measures to support retention in OAT after release. The findings from the final study identified groups who may benefit from targeted transitional support during community re-entry, those being people who initiated the OAT treatment episode during imprisonment and Aboriginal and Torres Strait Islander people. For people who initiated OAT in prison, retention may be improved by ensuring that people who initiate OAT are aware of community prescribing and dispensing processes, and pre-release efforts are made to establish supportive referral pathways in an area that the person is likely to reside after release. Additionally, prioritising referrals to experienced community-based OAT prescribers may also support retention, and international evidence has shown that peer navigator programs have also been beneficial in supporting retention in OAT and could be something that we could consider here in Australia as well. For Aboriginal and Torres Strait Islander peoples, supporting increased OAT prescribing within Aboriginal community-controlled health organisations may be an avenue to improve retention, as could the integration of ACCHOs into the provision of prison-based healthcare, effectively building those relationships prior to release. However, recognising that not all Aboriginal and Torres Strait Islander peoples may choose to access healthcare at ACCHOs, particularly for stigmatised conditions such as opioid dependence, culturally informed OAT prescribing amongst mainstream services may also reduce discontinuation amongst Aboriginal and Torres Strait Islander peoples. In addition to supports focused at the individual level, there are several structural reforms which also may support reduced OAT retention. So for those who weren't aware, and I've sort of mentioned it briefly already, Victoria's OAT system is entirely reliant on private prescribers and private pharmacies to do the prescription and dispensing of OAT, respectively. So we don't have any public clinics like many of the other Australian jurisdictions do to varying degrees. And there's a little bit more detail on this in the paper looking at non-fatal opioid overdose. But there's a real urgent need within Victoria to build additional prescribing and dispensing capacity. There's large geographical regions that are serviced by only one or two prescribers, and there's a very high burden of treatment prescribing, in particularly falling to a small number of GPs. So while public clinics may be beneficial to support increased prescribing and dispensing capacity, particularly in local areas of high demand, these responses may be less cost effective and feasible in areas outside of, say, large metro cities and large regional centres. And we also know that they may not be the most acceptable mode of OAT delivery for patients who may want to also access other healthcare services in the one setting. Integration of OAT training into medical and pharmacy degrees may also address some of the barriers for medical practitioners participating in Australia's OAT program. However, previous research has found that about half of GPs who complete training to prescribe OAT don't actually go on to prescribe. So it's unlikely that training alone, so building training into university courses for pharmacists and general practitioners, that these programs alone are likely to address the shortfall in prescribing that we currently have. There's some research to suggest that some of the barriers are financial, that participating in OAT programs may not be the best use of their time for generating income for the clinic. So creation of MBS items specifically to support OAT prescribing could be one option to improve this, as could the creation of or investment in community healthcare programs and that salary GPs to provide OAT and other holistic healthcare in the community. Additionally, consideration of how pharmacists and nurse practitioners could increase prescribing and script review support should also be considered. There's also the issue around treatment acceptability and how treatment retention could be improved by making treatment more palatable to people. Previously, pricing had been a major issue, and that was potentially an issue for retention during our work for these studies, I should say. However, as many would know, treatment was made massively more affordable in July of last year, and that's a very welcome reform. However, there's still a number of aspects of treatment that others may find difficult. Takeaway doses are one thing in particular that most people are subject to supervised dosing requirements, particularly during the transition from prison back into the community, where people may be required to attend a pharmacy up to 6 days a week. These are quite burdensome requirements and take a lot of time out of people's days and can interrupt other needs and other post-care plans around employment, education, even parole requirements and things like that. During COVID-19, social distancing necessitated a shift in how we provided OAT care, and 6 takeaway doses a week became the norm. There has been very little change in methadone-related overdoses, so there's some evidence there to suggest that it might be appropriate to reinstate or to maintain those takeaway provisions on a permanent basis. However, some jurisdictions are starting to wind those back, and we know that these can have a big barrier for retention. The high rates of resumption of injecting drug use, non-fatal opioid overdose, and OAT discontinuation also underscore the need for harm reduction efforts, which are available from the time of release to prison. access to take-home naloxone from prisons has been shown to be effective at reducing opioid overdoses, including for people recently reduced from prison. And we know that prison-based take-home naloxone programs are highly acceptable to people in prison. However, there's substantial variation in access to these programs across Australia. We also know that drug consumption rooms or supervised injecting facilities substantially reduce the risk of opioid-related deaths, needle sharings, and also improve access to co-located health and social support services, which are pivotal during community reintegration. However, as I'm sure most people here are aware, Australia only has 2 of these facilities, greatly restricting access, I guess, to people who don't live in those localities. Further, at least in the case of Victoria, there's also legislation that actually allows for court orders or parole conditions to specifically exclude people from having access to these services. And I think reconsideration of those legislative exclusions are warranted. As always, there are a number of limitations which should be considered when interpreting these findings. And while some of these are study specific, there are a few overarching limitations that I want to quickly highlight. The first is that Victoria doesn't collect any routine administrative OAT dispensing data. Accordingly, all the OAT exposure data that I've reported on today is based exclusively on self-report. Accordingly, this data may be affected by recall or social desirability biases. And this also resulted in the exclusion of participants who were lost to follow-up from most of the analyses. As the sample only included men who regularly injected drugs immediately prior to imprisonment, these results may not generalise to other groups. In particular, we know that imprisonment experiences differ systematically between men and women, with women who enter Australia's prisons being more likely than men to report a mental health disorder, poor psychological well-being, a history of self-harm, and chronic health conditions in the 12 months prior to imprisonment. Additionally, PATH did not collect data which we could use to determine opioid dependence. For the 2 studies which examined associations between OAT retention and healthcare access, the primary analyses likely included people who were not opioid dependent and therefore wouldn't have been indicated for OAT. However, in both of these studies, we undertook a series of additional analyses which restricted the sample to various levels of post-release opioid use as a proxy for likely opioid dependence. And in these sub-analyses, we observed similar effect sizes for each strata of OAT use. So while we cannot exclude the possibility that inclusion of participants who were not indicated for OAT impacted our findings, we're fairly confident that they hold regardless. And finally, the PATH sample size necessitated examining outcomes for people treated with methadone or buprenorphine in the same group. So we couldn't stratify according to treatment modality. Most PATH participants who used OAT were treated with methadone, so it's unclear whether the associations identified between OAT retention and the post-release outcomes extend to people treated with buprenorphine. And finally, the data I presented today were collected prior to the introduction of long-acting injectable buprenorphine. As many here would be aware, LABE is quickly becoming one of, if not the primary OAT medicine prescribed in prisons. Before I finish, or before we move on to questions and discussion, I'd just like to make a number of acknowledgements. So I'd like to thank the PATH study participants who graciously gave up a number of hours to participate in the study over the course of a couple of years. My PhD supervisors, Professors Mark Stoové and Paul Dietze, all of my co-authors on the studies, but with a particular shout out to Dr. Zana Wilkinson and Rebecca Winter, my colleagues at the Burnet Institute, in particular the fieldwork team, the Victorian Department of Justice and Community Safety, the Australian Institute of Health and Welfare, and the Centre for Victorian Data Linkage for their support with data linkage. At Monash University, who my PhD was enrolled through, and my funders, the National Health and Medical Research Council and the Monash Addiction Research Centre. There are some references. Thank you very much.
Thank you, Michael. A very comprehensive overview of the importance of OAT after release from incarceration, and very much appreciate your work in the space as well as yours, Dr. Stoové. So Mark, just to kick things off, I might ask what you see as just a general reflection on Michael's presentation, and then also what you see as the key public health strategies for improving OAT after release from prison.
Sure. Look, I'd just like to start by acknowledging the mountain of work that Michael did, not only around his PhD, but the PATH cohort more broadly. Anyone who's done justice health research knows what a hard slog it is, collecting data in prison and gaining the trust of people in prison, the operators of prisons and all of those sort of things. Michael did the lion's share of the data collection for PATH. I think we were at dinner the other night. I think we reflected that he may have collected over 1,000 baseline and follow-up, baseline interviews in prison prior to release, and then follow-up interviews in the community, which involved travelling all over the state of Victoria. People released from prison go to all points of the compass. And, really, Michael's work does underpin the quality of the study, including the fact that we were able to get at least one post-release interview for, approaching 85% of the cohort, and all 3 follow-up interviews for over half of the cohort. So I'd just like to congratulate Michael on the work that he did on that study, in addition to his PhD. Look, I think Michael's results in particular, the first study around, rapid resumption of injecting drug use post-release, but also the broader PATH cohort study findings really show that, the misguided belief that criminal justice systems and prisons have any rehabilitative effect for most people is grossly misguided. I think, our preference suite would be off the back of this data is that no one in Australia is incarcerated for non-violent drug-related offences. Largely, the socio-ecological conditions that drive people to incarceration who use drugs, not only are people return to those conditions post-release, but often they return to even less favourable, social conditions than when they went in the first place. The dislocation from family, housing, employment, community, does vastly more damage than any misguided belief that sending someone to prison may, mend their ways, so to speak. But in the absence of that broad law and, that broad reform, I think Michael's work and again, I'd highlight the broader outcomes from the study really point to the need to invest much more heavily resources and in quality of care and rehabilitation and reintegration services. We spend a tiny fraction of money on post-release reintegration services compared to the prison complex in Australia, and a little bit of forward thinking from our governments. It would be clear that money invested in quality rehabilitation services would pay back in spades in terms of future costs of avoided in terms of reincarceration, and people who use drugs are particularly affected by that rapid cycle of reincarceration, as demonstrated by some of Michael's findings. And look, Michael's work is really important also in underpinning the importance of retention in OAT. Now we know there's a lot of evidence around retention in community OAT programs, but Michael's work really adds that to that body of evidence to show that retention of on OAT both into prison, also the initiation and then retention of OAT post-release is super important for supporting positive health service engagement in terms of, access to primary care, and also avoiding the deleterious sort of health service contacts that are associated with acute care events in hospitals and emergency departments and ambulance attendants. So it's really compelling data to add to the suite of data around community retention, that these things are super important for, community to prison and prison to community transition as well. But yeah, just well done, Michael, on the scope of work.
Yeah, I have to reiterate that, Michael. I did not know about all the data collection and just connecting the two things with the difficulties that we see with, unstable housing after post-release and things like the fact that you were able to follow that up is at an 85%, follow-up rate is incredible. And also just reiterating the need for, well, A, more resources, and B, more research in the area. I know that in the specific area of post-release incarceration, I know that there's been a couple of reviews at Endark on retention and OAT. I believe there's only 2 when we did a review in 2021, and Crystal McDonald's recently released, and I think it was 3 studies, but just emphasizing the importance of the post-release incarceration and OAT need for research, especially given the rates of overdose and suicide, as well as other cause of mortality after release, is really important. I just want to reiterate to the audience as well to use the Q&A function for some questions. Naomi, we'll get to yours in just a moment. But first, I just wanted to ask you, Michael, and as you as well, Mark, thoughts on the potential for long-acting injectable buprenorphine. I believe your study was prior to that, from what I understand, and so I'd be interested to hear your thoughts.
Yeah, absolutely. Thanks, Tom. It's interesting to see how and understandable how the prison's starting to shift to predominantly prescribing long-acting injectables in prisons. Obviously, it's easier to provide that treatment within the prison compared to the daily dosing requirement and all the movement and the staff time involved in the prescription of Suboxone in particular. I do, I guess I wait to see what the results are. I know that Adrian Dunlop's got a body of work in process at the moment, so particularly keen. I think he's got a session coming up at APSAD where there's a few studies there reporting on a few transitional outcomes relating to long-acting injectable. So I'm really keen to see those results as they come through. I guess philosophically, I'm always very excited about new options for treatment. I do worry about the potential for people being pushed onto treatments and the loss of sort of the patient at the centre of the treatment episode, particularly in context where, other avenues for patient care and decision-making in prisons fairly limited for people. There's a little bit of data from Canada to show that, points to the potential disruptive effects of people swapping between OAT modalities while in prison. It was difficult to tease that out. There's a study in particular that, the control groups or comparison groups aren't ideal, but there's a little bit there to suggest that, swapping people on treatments during prison was associated with a number of poorer outcomes post-release. So I worry a little bit about shifting people. The other thing I guess I also worry about is looking at some of the NOPSAD data recently, the number of people in prison on LABE compared to in the community in a couple of jurisdictions is just as, if not approaching, higher. And I get concerned about the resources within the community to maintain depot prescribing and dispensing. It's a different skill set. And while obviously the number of pharmacy visits are fewer, those visits, when they do happen, are more resource intensive. And are those skills sort of well distributed across the state? As Mark hinted before, I covered just about every corner of Victoria doing follow-up interviews for this study, and went to some very small towns that I probably won't have reason to go back to again. I would be surprised if they have people in those settings
Right.
who are engaged in. I mean, I'm speculating on that, but I do wonder about it. Mark, anything to add?
I'm just going to say the words patient-centered care. And, this can't be a tail wagging the dog type technology that, involves the wholesale movement of people across to LABE. While it may be suitable for people on existing sublingual buprenorphine programs in prison, the fact is that, many people who are opioid dependent, their preference is for methadone. And they do quite well, and thank you very much on methadone, as well as, the prescribing and dispensing complex in the community is there and established. And if people, if people are going to transition onto or initiate onto long-acting bup in prison, there needs to be a conversation with the individual about what that looks like post-release as well, to make sure, again, pointing to Michael's work on retention, there is no point having them start on LABE with the prospect post-release that they really struggle with maintenance on LABE. So it needs to be a conversation that is had with the client and be centred around the needs and the wants of the client.
Absolutely. Yeah, looking at the disparity too, I would be quite surprised if patient autonomy didn't play a role in the disparity between the rates of prescribing in prisons versus the community. And I think that we definitely need to make sure that obviously patients are at the center of the care, and looking at just what that post-release period would look like is really, I think, a new, I don't say complication, but in some ways it is on, say, for example, the day that you get your dose afterwards versus like your next dose once you're released. And simple things like that can throw, in a really difficult period when in someone's life, returning back to the community, adding another complication to that, just or helping depending on the individual. So
and I might just flag that the National Addictions Medicine Network has just put the finishing touches on a national consensus statement about best practice OAT prescribing in prison, and it's likely that an NJA paper will be published shortly and a link to the longer consensus statement. So people should keep an eye out for that, because the old community OAT guidelines they're pretty old now, but this updated consensus statement will deal specifically with best practice guidelines around OAT in prisons, including transitions in and out.
fantastic. Definitely be looking that one up soon. So Naomi has a question in regards to injecting drug use for the study, Michael, and whether or not it was just opioids or all people who are all injecting drug use.
Yeah, so it was all injecting drug use. So we didn't restrict that paper to just opioids. From memory, though, although not having the raw data up in front of me at the moment, there was a lot of polysubstance use in the cohort. So a lot of heroin and crystal methamphetamine injection within the cohort.
And do we have any insight to the main causes of morbidity or mortality afterwards?
Yeah, sure. So on the mortality front, so we're in the process of accessing the linked data for the 5-year follow-up period. So looking just at the 2-year period, off the top of my head, we had, I think it was 20 or 25 deaths in the cohort within the first 2 years of release. Half of those were opioid overdoses. And then I think about half of the remaining 10 or 12 related to suicide.
Wow.
Yeah. So, I mean, horribly high rates of mortality and some really awful circumstances around those deaths, but unfortunately not remotely unexpected, I should say, and in line with what we've seen from other studies and have been seeing for decades now, and yet we're still not making any substantial inroads there, unfortunately.
A question from Emily, just briefly, in regards to the rates of endocarditis and MRSA. If you had an idea of that.
Yeah, so off the top of my head, I don't know. The person to ask would be one of my colleagues at Endry, Dr. Samantha College-Frisbee. So she has done some work in the PATH study, unless Mark knows off the top.
So Sam did some analysis for us on the irids and invasive infections. Off the back of some controversial findings that came out of New South Wales, around the protective effect of incarceration on those sort of outcomes. It actually indicated, yes, very low. So we use hospitalizations for irids and invasive infections as the primary outcome. There were relatively low rates while in prison. We're unsure about whether that is related to access to transportation to prison and the ability to elevate concerns that people have around infections in prison systems. But we actually saw a very elevated rate in the first 4 weeks post-release, but then tapered over time, which we're still trying to wrap our heads around in relation to the potential for unsafe or unclean injecting events in prison prior to release, contributing to that being picked up, presenting to emergency department post-release, and something is diagnosed and then hospitalisation occurs, or whether it's something to do with the specific post-release environment in those weeks that can be chaotic, that can be high rates of homelessness and those types of things, whether that contributes to the high rate. But we detected low rates of hospitalisation in prison due to irids, but relatively high in the immediate post-release period, which we're still looking into.
Yeah, it's definitely a big concern, especially with the lack of NSPs in prisons. Stuart asked a question on the impact of OAT being listed on the PBS, and what will it, or how could it potentially impact our capacity to study treatment adherence over time, particularly for people who experience incarceration? And purgatory.
Yeah, great question, Stuart. I'm really excited, not just for people who are on OAT that now get much cheaper medicine, but it means in Victoria we should actually have some dispensing data now, which will be fantastic. So that is excellent news for community prescribing or for people who are out in the community. What it means for incarceration is a little less clear. So I'm not sure how that will, I guess, intersect with prison healthcare, given sort of some limitations, or most PBS medications access doesn't happen in prisons. But then there are a couple of Schedule 100 or Section 100 medications that are funded in prison through those initiatives. So to be honest, I'm not entirely sure yet whether the records for prison OAT dispensing will show up in PBS dispensing. If anyone here happens to know that, please put it in as a question that it isn't a question, and let me know. Because otherwise we need to try and work out a way of, particularly I guess for treatment retention, getting some kind of data out of the correctional health services in order to keep examining that.
And adjacent comment on that would be the lack of Medicare for people who are in prison, and so that may, I know, get S100 and all that, so it may not play a role, but it is an important thing to acknowledge, and something that does need to be changed. I'll end it off with one final question. Did you see a delay in post-release treatment due to inmates' records not being updated with their preferred primary care providers, particularly for Aboriginal and Torres Strait Islander men transitioning back into the community?
Great question. We didn't collect any specific data that I can point to answer that question. Anecdotally, talking to some of the men, doing those 3-month follow-up interviews and getting a sense for what was happening for the men around their healthcare, that did happen in some circumstances where either people were released quicker than expected, and so health referrals weren't made, or were people's post-release circumstances changed, and so their health records were transferred to one provider at their request, but they'd ended up actually accessing other healthcare providers because their accommodation fell through and they ended up on the other side of Melbourne or in a regional city instead of, down in Melbourne or things like that. But unfortunately, I don't have any hard data on that, but we know that the timely transfer and provision of healthcare records is a barrier for continuity of care, not just for OAT, but for a range of different healthcare matters for people transitioning out of prison.
Absolutely. I'll just actually give some final comments there from Jennifer, noting that small community hospitals and EDs and AOD workers are central to ensuring people on LIAB are able to continue, and 50% suicide morbidity through IV drug use was so Margaret's comment is in regard to ice use or methamphetamine use and the relation to suicide there among people with opioid dependence. And I think it's an important thing to consider as well that we know the high rates of polysubstance use among people with opioid dependence. And finally, Emily asking if these studies are available to read, and they are.
Yes, they certainly are, and they're all published via open access as well. But Emily, if you want to grab my email, I'm happy to share links out to those open access articles with.
Fantastic. Alrighty. Well, Michael and Mark, thank you so much again for attending today and sharing your fantastic work in the justice health space. I'll also give a note to the next webinars coming up. We'll see on the screen now. But everyone, thank you for attending. And again, thank you to Mark and Michael. Very much appreciate it.
Thanks for inviting us.
Of course. Thank you.
Thanks for having us, Tom.
Of course.